So my practice is 100% cancer rehabilitation medicine, meaning that I treat impairments that are neurological, musculoskeletal, cognitive, in people with a history of cancer across the continuum. I'm fortunate in my practice to have a leadership role in rehabilitation and specifically oncology care. So that means at the cancer center level, I'm on the leadership and I'm in charge of overseeing our rehabilitation efforts, and that means ensuring quality. On a programmatic level, my colleague and I, who also does cancer rehabilitation, we manage service lines. So there's a physical medicine oncology service line throughout the hospital that reaches acute care, and we are in charge of that, but also on the inpatient rehabilitation side of things. We get to see patients who are admitted. We have a specific team of therapists that we work with. Then they can come to our inpatient rehab unit and we see them outpatient, or maybe we just see them outpatient. But it's nice to have that level of control, and I've quite frankly got to add quality measures to the cancer center's overall kind of assessment of patients that include function and rehabilitation. I am certain that we provide value to patients because I know that there are certain aspects of care that only a physiatrist can provide to these cancer patients, cancer survivors. Whether it's pain, whether it's cognitive, whether it's a tricky musculoskeletal diagnosis that we make, it's really refreshing to constantly see that, oh, I'm the one who's best suited to see this patient, and I can provide something that no one else can. And that's not to say that the other providers, are failing in any way, but that's my practice and that's what my specialty is. I think it's invaluable to have a physiatrist as a part of a multidisciplinary team in general, and with cancer care, everything has to be multidisciplinary. You have to get the right diagnosis, you have to treat the symptom properly. And so an example is there's anything from spine oncology, where it's neurosurgery, radiation oncology, and PM&R, or it might be a tumor board where we attend tumor board to say, well, this is the sort of expected function if you go with an amputation versus a limb salvage procedure, and this is what you can bring back to the patient. So there's infinite numbers of examples I can give you, but I'll leave you with those two. So building a program involved a lot of meetings and sort of a roadshow, as I like to call it, where I'd go to a diagnosis group, breast cancer, sarcoma, head and neck cancer, and lay out this is what we can do. And really it was about applying rehabilitation techniques that any physiatrist has and saying this is what is different about your population after the radiation, the surgery, etc. And this is how we can apply our skills. And it was novel to them. This is something that wasn't being done, and it wasn't a terribly hard sell, I gotta say. I think physiatrists in general need to constantly show our value and how we're different than other rehabilitation providers, and what specifically a physician can do to intervene for a patient. And that includes diagnosis and management, and quite frankly, helping to run a multidisciplinary team.